the patient is carrying CT scan with all that information in hand. Why to repeat unnecessarily? The anatomy is not going to change at all. But what we want to know, whether the CT scan is adequately, done, whether we have complete information from the patient what is having CT scan in hand. So
Right.
that's why we order always CT scan in digital format. And with our software, we can reconstruct to all planes to get maximum information. That's the information. That is why the onus is on surgeon to read CT scan on our own rather than relying on the radiologist's information. We want anatomical details. With this, software, we can measure the anatomy in some millimeter, fashion, which is important sometimes, very, very critical from cochlear implant point of view. So I would like you to interrupt me any point of time. You want to add on anything? I know anything, a single word coming from you is going to be very, very important for everybody. Thank you, Kapil. And I can see on the screen Dr. Markande Tiwari with us, who is the head of department at the prestigious Government Medical College, Goa. Thank you, sir, for being with us and enlightening us with your experience today. Thank you so much. So before going to the CT scan, as I said, we want a digital format so that, and where I am running my CT scan on this, Radiant DICOM viewer, wherein I can get the maximum dynamic three-dimensional information, which is useful from cochlear implant point of view. CT scan, a high-resolution CT scan temporal bone has to be read from different ways, from different perspective when you plan different surgical procedure. For example, if I am planning otosclerosis surgery, we have a case of otosclerosis today to demonstrate. In that scenario, I will be reading the CT scan from different perspective to touch upon or to look at those important information which are more relevant from the otosclerosis surgical point of view. Here, I will be reading the CT scan more importantly from the cochlear implant perspective. Anything which is related, any anatomy which has an impact on the cochlear implant surgery, which can change the overall, outcome of the cochlear implant surgery, which can change the procedure of the cochlear implant surgery required. Anything which has an overall impact on the cochlear implantation surgery, we are going to discuss. So what all to be discussed on CT scan? We need all axial, sagittal and coronal planes where our radiologist, shoot the CT scan in the axial plane always, and you can see it is fine section, submillimetric 0.6 mm at the left lower end. You can see 0.6 mm sections. We have 196 images. You see the area scanned by this, and with this software, I can convert this to three-dimensional now. This is very important teaching tool for the junior colleagues as well. If you are reading the CT scan this way, and you can read the anatomy in all three planes. For example, if I take my cursor in the axial section on the basal turn, you can see in all planes where the basal turn is, and this improves your overall understanding of the CT scan in three planes. So this is an amazing teaching tool, number one. Number two, it gives you dynamic information. For example, what do I mean by dynamic information? If I want to see the facial nerve course, if I want to see the cochlear turn, I can see dynamically the CT scan through this, DICOM format. See the facial canal, the vertical facial canal, right from the, the foramen, the external foramen, the stylomastoid foramen. I can see the entire course of the facial nerve, how it is traversing through the temporal bone, how it is in relationship with the various important structures like lateral semicircular canal, the round window, how it is important to all these structures. And this is important from cochlear implant perspective. So we need to know what all to be seen on CT scan during cochlear implantation, though I'm not going to be in very, very details as the patient is, being prepared. So I will touch upon quickly the important things to be seen on CT scan from cochlear implant perspective. So this is axial section. I will mention every time what all to be seen on axial section, which gives best information, what all for information which is gathered best on coronal as well as sagittal sections. So we need to know all that information. Now, so I am running my CT scan from top to bottom. Kapil, am I audible to you?
Yes, sir. Perfectly.
So feel free to interrupt me anytime, dear.
No issues.
See this. I'm running from top to bottom, and every time I move, this is 0.6 mm slices. Every single movement, I will be moving by 0.6 mm. That is beauty of fine section. If suppose I have a 4 mm, 5 mm CT scan, with every slice I will jump by 4 or 5 mm. That will be too inadequate, in terms of giving information in temporal bone, wherein a sub-millimetric anatomy can change the overall scenario. Now see, the first structure to be seen is the superior semicircular canal, the non-ampullary end and the non-ampullary end of the superior semicircular canal. You can see here. See this again, the superior semicircular canal to begin with, then this ampullary end, non-ampullary end. You can follow the ampullary end. This is important. Though the superior semicircular canal per se is not important from cochlear point of view, this is more important, we will see in a otosclerosis point of view. But for everybody's information, this is best seen on coronal sections. Let me show you the lateral superior semicircular canal is best seen on coronal section. Can you see my cursor? That is the vestibule. See all the three canals, the lateral canal going laterally here towards the mastoid hair cells. This is superior canal going towards the middle canal fossa. And if I want to see the dynamic superior canal, the full course dynamically, see this. See the bone over the superior canal which is intact. That is important to know if there is any superior canal dehiscence. I told you that is more important, more relevant from in otosclerosis surgery than in cochlear implant. But any malformation of the semicircular canal is very, very important in cochlear implant surgery. If there is any malformation in the semicircular canal, we must be prepared to see the abnormal course of the facial nerve. That is important. Facial nerve is an important, anatomy in cochlear implant surgery, and to protect the facial nerve is a very important part of the surgery. And facial nerve malformation, abnormal courses are common once there are malformation of the semicircular canal. So in CT scan, the first thing we see any malformation of the semicircular canal. See, this is superior canal and forming the vestibule here. This is vestibule. Now coming back here, what all we see here during this course, what is this? This is round window. This is round window here. This is round window. That is the cochlea. That is round window. That is the facial nerve here underneath the lateral semicircular canal. So best thing to see the semicircular canal, all the three canals together dynamically. To see any malformation, we need to look at the coronal picture. That is one important thing we can make it. So this is one thing to point out, and we should not miss any malformation of the canal, particularly lateral canal. Lateral canal malformation are almost always associated with facial nerve malformations. Now coming down, see this. This is superior canal. I'm coming quickly down. What we see here is the vestibule. This is the vestibule, and from the vestibule, both the ends of the lateral canal looking like a signet ring. Can you see this? That is the ampullary end of the lateral canal. That is the non-ampullary end of the lateral canal. And this is very important anatomy here. This is vestibule. That is lateral canal. We need to see all the canals together. This is posterior semicircular canal. See, this is vestibule. Looking at the orientation of the cochlea in the body, this is lateral, this is anterior, this is posterior. And what we see, this is the posterior semicircular canal again emerging out from the vestibule. This is the ampullary end of the lateral posterior semicircular canal emerging out of the vestibule. Another thing to be important and looked at is the vestibule. The dimension of the vestibule is very important. See, many a times in many of the malformation of the inner ear, the enlargement of the vestibule is one of the associated malformation along with the cochlear malformation, and we need to be very careful not to, overlook this anatomy if it is enlarged. An enlarged vestibule and an enlarged vestibular aqueduct. Can you see this? This is the vestibular aqueduct. Can you see? This small. See this, this is vestibule. From the medial wall of the vestibule run the vestibular aqueduct, which houses the endolymphatic duct, which opens at the posterior petrous surface. This is the vestibular aqueduct. We need to see in all our CI patients very carefully if there is any enlargement of the vestibular aqueduct, like which is common, in Mondini malformation, wherein there is an incomplete partition of the type 2 of the cochlea, and vestibular aqueduct enlargement. Vestibular enlargement is seen in IP1 as well. And the importance of the vestibule and the vestibular aqueduct enlargement is maybe associated with, gusher, not gusher, but at least oozer, because this endolymphatic duct or enlarged endolymphatic space is responsible for transmitting the CSF pulsation, which may result in sensory hearing loss and which may result in pulsations of the perilymph when you open the, inner ear, when you open the cochlea, and can result in some sort of oozing, sometime even in gusher as well. Uncommonly, gusher is most commonly associated with, abnormal, communication of the lateral end of the canal with the cochlear base. So what we have seen so far, the semicircular canal, the vestibule, the vestibular aqueduct, everything is important. Now, as we go down, the another important thing we need to look at this point of view, this is internal artery meatus. A normal size internal artery meatus is something which is, safe for the cochlear implant patient, safe and, important from different point of view. Let me change, what do I mean by normal size? With this software, I can measure the dimension. See, the dimension is 4.4 mm, which is normal dimension of the intra-artery meatus in mid segment. Now, what happens? Sometimes this intra-artery meatus may be bulbous, dilated, and should warn the surgeon of having abnormal communication with the cochlea to give a gusher. See, all these things which can give rise to gusher, one must be prepared with to deal with it, because gushers can have impact on the surgical procedure. In overall surgical planning, there are many situations wherein the gusher is imminent, which you can pick up by the radiology, like in IP1, common cavity, IP3. Those are the situations which are more likely to give gusher, wherein the, stopping the cerebrospinal fluid egress is very, very important. And many a times in high risk individual, we change our surgical technique to a subtotal petrojectomy implantation, which gives us the best, technique to tackle the CSF gusher. So all this anatomy, all this CT scan has a relevance on choosing the surgical technique as well in difficult situations. So the role of the CT scan, as I said in the beginning, is to know any difficulty one can encounter. You can preempt by the CT scan if somebody is going to encounter any difficulty which can have a significant impact on the overall surgical procedure. Now, besides the cochlear implant, now